Good afternoon.
Afternoon.
Hi there, Prof. How are you?
Good on yourself.
Well, thank you. I'm just going to show you my face. Nice to meet you, virtually.
Oh, nice to meet you too. I'm not sure if you can see my face.
Yes, I can see now.
Yeah.
Lumka, do you want to start with testing the intro slides and see if you're comfortable?
Can you see my slides?
Yes, looks good.
Let me see if I can progress. Okay.
Yeah, looking good.
And then I'm fine on my side.
Perfect. And then, Prof, would you like to share your slides?
Should I stop sharing on my side first, Nicole?
Mm-hmm.
Should I stop?
I think
Oh,
multiple
different
people can
things.
share, but there we go. Now it's
Can you see my slides?
good. Yes, looks good.
Are they progressing?
Yes, perfect.
Yeah.
And both of your audio is sounding good as well. Any questions about the introductions or anything?
Nothing from my side. I'd like to share one more, if that's possible.
Sure.
Can you see the slide?
Yes, I can see. Very cool.
Okay, thank you.
Awesome.
Nicole, I guess I'll see hers once I've stopped sharing because I can't see them on my side.
I'm gonna share the introductory video. It's just announcements for deep dive. And then at 4 o'clock, I'll stop the video, and Lumka, you're welcome to share the intro slides. And then if there are more than 40 people in attendance, then you can just go ahead and start the introductions.
Okay, so should I stop sharing or I'm fine just leaving my thing on?
If you could stop sharing just for now and then reshare it for, that would be easiest.
Okay.
Awesome.
Good afternoon, everyone. Nicole, can you just confirm if I'm audible?
Yes, we can hear you nicely.
Yeah. Afternoon, everyone. Welcome to this afternoon's session. Trying to get my slide to progress. Just gonna reshare again. So welcome to this afternoon's session, which is a collaboration between Blood SA and the University of Pretoria in partnership with the South African Clinical Haematology Society and SAFET. I would also just like to acknowledge and thank the management that are responsible for organizing the sessions that you enjoy on this platform. That includes Prof. Estelle, Dr. Khadin, and Dr. Nicole. Just a few housekeeping notes. Be aware that all the sessions are recorded and they can be found on the Blood SA website. You just need to go on the website under resources and go to deep dive. We're planning for the session to be an interactive session, so you're welcome to put in your questions and comments in the chat box. And also at the end of the session, you will be given time to unmute and ask questions if that's your preferred mode. It is a CPD point accredited session, so CPD points are submitted to the HPCSA. But for you to be able to get CPD point, you need to attend the session for at least an hour and just ensure that you've entered your HPCSA number correctly. If you want to be part of the mailing list, you can also join the mailing list by going on the website under resources and then subscribe to Deep Dive. The committee would like to get feedback. So at the end of the session, there's always a feedback questionnaire to complete. If you can please complete that, it helps. And it is anonymous. Just an announcement, there is a conference that's going to be taking place in Cape Town on the 19th as the HHT Horizon, which is organized by Blood SA. There is a link which has already been posted on the chat for the people who would like to register for the Congress. So this afternoon, we have the pleasure of having a visitor from Department of Oral and Maxillofacial Pathology, and she will be discussing topic when viruses converge, EBV and HIV in head and neck lymphomas. The program is basically going to be her presentation, then we'll have questions and answers at the end. If I can just briefly introduce her, our visitor is Professor Tulufolo Kumwane. She is an oral and maxillofacial pathologist, and she's the current head of oral and maxillofacial pathology at the Department of Oral Maxillofacial Pathology at the University of Pretoria. She has a 10-year experience as a professional. Then she's had over 15 years as a dedicated worker in academia. She's qualified from VETS, and she also works as a part-time consultant at Pathcare Laboratories in Pretoria. Her research interests include head and neck lymphomas, which is why she's the suitable person for this afternoon's talk. She is a recipient of the SMRC grant in non-communicable diseases and lymphoma research and is currently pursuing her PhD at UP. Also, a reminder that next week there's a break for holidays, so there will be no session for deep dive. Over to you, Prof. Kumwane, if you're ready.
Good afternoon, colleagues. Just to check, can you see my slides?
Yes, we can see your slide. You can just proceed to the presenter mode.
Okay. Is it on presenter mode now?
Yes, thank you.
Okay, thank you very much. Thank you, colleagues, and thank you for your attendance this morning. Sorry, this afternoon. It's been a long day. My name is Sulufelo Kungwani, and I'm an oral maxillofacial pathologist at the University of Pretoria. And my interest is on head and neck lymphomas, however, main interest being on HIV-associated pathology in the head and neck. So today I'll be presenting on the EBV and HIV in head and neck lymphomas. So my presentation will include what is currently available in South Africa and with specific focus on what we are doing at the University of Pretoria. So the lymphomas that I'm going to be presenting today will be in the common lymphoid progenitor and with specific emphasis on the B-cell lymphomas. However, I will touch based on our current research on other types of lymphomas that are associated with EBV. South Africa has currently about estimated 8 million people living with HIV and AIDS. This is based on the current statistics, national statistics. And we all know that people who are living with HIV and AIDS are prone to developing viral-driven malignancies. And these malignancies include Kaposi sarcoma, cervical cancer, and hematolymphoid malignancies. And these are caused respectively by the HHV8, HPV, and EBV viruses. And if you look at the two, they're in the herpes viridae family. So when it comes to Epstein-Barr virus, it's a double-stranded DNA virus of the herpes viridae family, also known as the HHV4. So they're named on the time of discovery. So this was the fourth herpes virus to be discovered. Epstein-Barr virus have an affinity to infect B lymphocyte using the CD21 receptor. And there is a co-receptor, the GP42, that binds to the class 2 molecules, and this helps with the viral entry. Outside infecting B lymphocyte, EBV can also infect epithelial cells, and hence is important in the pathogenesis of nasopharyngeal carcinoma and oral hairy leukoplakia, which is an HIV and AIDS defining lesion. So when you look at the EBV lymphoproliferative disorders, they are associated with a different latency pattern, and the patterns depends on the host immune status. And hence they're very common in patients who are HIV positive because of the immune suppression. The latency pattern can progress from latency pattern to latency from type 3 to type 1, and this is associated with different types of lymphomas. So I'm going to explain the latency patterns as follows. So once infected with EBV, the B lymphocytes once infected with the EBV, the EBV virus is transcribed into the nucleus, and once it's transcribed, the virus elaborate genes. So the genes, you have the SPEM virus nuclear antigens, you have the SPEM virus RNAs, and then you have latent membrane proteins. And this is what happens with the initial infection with the cells. And in this instance, the patient will have what is known as infectious mononucleosis. And then to avoid immunosenescence or also following a bout of immune response, the EBV virus undergoes latency in the B lymphocytes. And then it's during this latency pattern that you end up with lymphoma development. So the latency pattern is different based on different lymphomas, and also is different based on the time frame. So depending on the immune status, once a person is or the cells, the B lymphocytes are infected with Epstein-Barr virus, there is elaboration of all antigens, and hence the EBAs, the EBNAs, then LMP2, 1 and 2 that are elaborated. And in this phase, the patient has infectious mononucleosis. And depending on the immune status, that can progress in the proliferative B lymphocyte in latency pattern number 3. And also in that you have this post lymphoproliferative disorders and also latency type 2. But if you look at the expression of these antigens, the EBAs are expressed irrespective of the latency patterns. This is followed by the EBNA ones, which is expressed in most of the latency patterns except latency pattern 0. And then if you look at the LMPs are latency membrane proteins. They often are expressed a month or so later following infection or years following infection, depending on the patient's immune status. And also some lytic genes which are important in the virus replication within the cells in the initial phases. So these are very important because we look at this to evaluate at the latency pattern of the disease. And what is important is that we use in pathology Epstein virus encoded RNA-ish to diagnose EBV infections in lymphomas, because this is expressed in any latency pattern and is very important in the diagnosis of EBV infection. So the issue comes in with the LMPs, because the LMPs are mostly expressed in Hodgkin lymphomas. So the only useful to use as immunohistochemistry in patients with Hodgkin lymphomas. So one needs to be careful when ordering LMPs for other EBV-associated lymphomas. So for my talk, I'm going to concentrate on the EBV lymphoproliferative disorders in HIV, with specific emphasis in the head and neck region. And the first thing that we often see in patients that are HIV positive is the Epstein-Barr virus mucocutaneous ulcer. And this is followed by Burkitt lymphoma, diffuse large B-cell lymphomas, and plasmablastic lymphomas. The prevalence of Hodgkin lymphomas in the head and neck in HIV, it's very, very low, to a point when I looked at the past 5 years, there are very few reports of Hodgkin lymphomas in HIV. And hence, I'm not going to discuss it for this talk. But in the beginning of the HIV pandemic, Hodgkin lymphoma was the #1 lymphoma in patients with HIV. So the reason we're not seeing it a lot, it's probably because of the introduction of antiretroviral drugs, because Hodgkin lymphoma is common in the head and neck region, and hence maybe that will explain why it's not seen recently in patients that are HIV positive. The Epstein-Barr virus mucocutaneous ulcer, it's an EBV-induced lymphoproliferative disorder, and is often associated with immune suppression in HIV, but can also be seen in patients in post-transplant settings or patients with SLE or any other autoimmune disorders taking immune modulation therapy. And one of the things that is common is that it can be seen in older individuals due to age-related immunosenescence. These ulcers present as shallow and sharply circumscribed mucosa or cutaneous ulcers, and they involve anywhere from the mouth to the anus. And they present with this polymorphic infiltrate of immunoblasts, which I'm going to showcase just now. And what is important is that you have in this polymorphous infiltrate, this Hodgkin and Steinbeck-like cells. So this is a case of EBV mucocutaneous ulcer, and one can see there's an ulcer on the floor of the mouth on the left side. So this is the tongue, this is the teeth, and we're looking at the floor of the mouth, and in the ventral surface of the tongue, you have a an ulcer with rogue margin. And I've taken the slides from the article, the journal article, but you're supposed to see a polymorphous infiltrate. And then in this polymorphous infiltrate, we have these larger cells that are CD20 positive, and the same cells are CD30 positive, and there's a background of T lymphocytes. And however, some of the cells, the larger cells, can also express CD3, which is a T cell marker. And then to differentiate it from Hodgkin lymphoma, the cells are CD15 positive, CD15 negative. And what is important to nail the diagnosis is the presence of a nucleus staining with Epstein-Barr virus encoded RNAs, the IBA-ish. And the good thing about this ulcer is that it can heal with or without treatment, and depending on the patient's immune response. So if a patient is HIV positive and they go on antiretroviral drugs or treatment, then the lesion can heal. And if patient is immunosuppressed and you adjust the medication, it will also heal spontaneously. So that's a good thing about the EBV mucocutaneous ulcer. So the take home for the EBV mucocutaneous ulcer, firstly, it presents as an ulcer of the skin, the mucosa of the gastrointestinal tract. There may be reactive lymphadenopathy because it's an inflammatory ulcer. But there is something else that is important, is that you can have immunoglobulin heavy chain gene rearrangement or clonal T cell receptor rearrangement. And that's very important because if you only have the tissue and they don't tell you where the tissue is coming from, it's easy to go down a wrong path and call it a B cell rich, a T cell rich B cell lymphomas, because they tend to look like them. And then also, another thing to consider is that the EBV DNA is undetectable in the peripheral blood, so you still have to do a blood sample just to confirm. And also the lactate dehydrogenase levels are within the normal limits, and also the interleukin-2 receptor also within the normal limit, and there is spontaneous resolution. In the rare cases when the lesion does not resolve, patients are treated with R-CHOP because the cells express CD20 receptor, which is a B cell marker, and hence they can be treated with rituximab. But this is often in rare cases. And also there are cases that progresses to the EBV positive diffuse large B cell lymphomas. I don't know if there are any questions at this level. Should I continue?
I think let's proceed and then we'll take questions at the end.
Okay, thank you. Like I said earlier, there are cases that progresses to the EBV diffuse large B-cell lymphoma, not otherwise specified. And also on histology alone, the EBV mucocutaneous ulcers can mimic the EBV diffuse large B-cell lymphoma. So the EBV diffuse large B-cell lymphoma was previously known as the EBV positive diffuse large B-cell lymphomas of the elderly. This term is no longer used. And patient has a history of immune senescence compared to patients that have a history of immune deficiency that we've seen with EBV mucocutaneous ulcer. So unlike what was written before and what was known about EBV diffuse large B-cell lymphomas, is that they can occur at any age. There's been seen in an age range of 4 to 88 years, hence the term the EBV positive diffuse large B-cell lymphoma of the elderly is not the right term to use. And similarly to mucocutaneous ulcers, they can present with extranodal sites, but there is mostly nodal disease that is more prevalent. And in terms of histology, they tend to look identical to the EBV mucocutaneous ulcer in terms of you have a reactive background, and in this reactive background, you have this Hodgkin-Rustenburg-like cells. And the cells also have the same immunoprofile where they express CD20, CD30. They can be MAM1 positive and they're IBA-ish positive. And unlike the EBV mucocutaneous ulcers, they do express a LMP1 in 76% of the cases. So this is the H&E picture of an EBV diffuse large B-cell lymphomas, and you can see that you have this larger Ristenberg-like cells, and then in the background of a polymorphous infiltrate of lymphocytes, plasma cells, and occasionally you can see eosinophils. And the larger cells are positive for CD20, which is a B-cell marker, and also positive for MAM1. MAM1 is a post-germinal center marker, and is also commonly seen in plasmablastic differentiation. In addition, the cells tend to express PD-L1, and which is very important in the treatment and in the prognosis. So how do you then differentiate between EBV mucocutaneous ulcers versus EBV diffuse large B-cell lymphomas versus Hodgkin lymphoma, the classic variant? So when you look at the EBV mucocutaneous ulcer, it's mostly extranodal. They've never been seen in the nodes, so it's an extranodal disease. However, the EBV diffuse large B-cell lymphoma can be seen nodal in an extranodal site. Classic Hodgkin lymphoma is a nodal disease, but there are rare cases of mucosal or cutaneous involvement. In terms of histological findings, they tend to show identical features, and sometimes it becomes difficult to differentiate the three because they will have a polymorphous infiltrate, and then in that you have this Ristenberg-like cells that you can see. Remember, the classic Hodgkin lymphoma has different variants, and in the mixed cellularity type, that's when you will see the large Ristenberg cells in the polymorphous infiltrate. And in terms of histological finding, especially immunohistochemistry, they all stand for, the two stands for CD20 and a PAX5, and they're also positive for CD30. And unlike classic Hodgkin lymphoma, classic Hodgkin lymphoma cells do not express CD20, but they do express CD30. And they're all, the two are EBA positive. However, EBA expression in classic Hodgkin lymphoma depends on a case, so not all of them. So at the percentage, the prevalence of EBV in classic Hodgkin lymphoma is up to 30%. So in the peripheral blood, the lactate dehydrogenase range will be lower in EBV mucocutaneous ulcers. They will be elevated in EBV positive diffuse large B-cell lymphomas, and they can also be elevated in classic Hodgkin lymphoma. But the most important thing is the interleukin-2 receptor, which is lower in the EBV mucocutaneous ulcer and mostly higher in the lymphomas, diffuse large B-cell lymphoma and the classic Hodgkin lymphoma. And the EBV mucocutaneous ulcer have undetectable EBV DNA in the peripheral blood. So the next entity that I'm going to discuss that is common in the head and neck is a diffuse large B-cell lymphoma. Currently, there are 13 variants that are recognized by the 5th edition of the WHO, and those variants are based on the immunophenotype, the clinical presentation, and the viral expression. In addition to these 3 variants, there are specific diffuse large B-cell lymphomas with gene expression profile, and also genetic subtypes of diffuse large B-cell lymphoma depending on the genes that are expressed. So if we look at the variants based on the WHO, current WHO, you will see that the morphological or immunohistochemical immunophenotype profile is based on how the cells look on histology and how they stain, while the clinical subtypes are based on their location. So for instance, if the primary mediastinal large B-cell lymphoma will be found primarily in the mediastinal. And then also we have the viral driven, which the EBV diffuse large B-cell lymphoma not otherwise specified falls under, which we just discussed now. Then there's another entity called HHV8 positive diffuse large B-cell lymphoma. And I don't know, I've always had qualms about it because I feel like the name does not actually represent what it actually is, because the HHV8 positive diffuse large B-cell lymphomas, they're also positive for EBV. So they have dual expression of both HHV8 and EBV. The EBV expression is actually around the 80% range, depending on which article that you read, but they do express EBV. And hence, maybe in the new classification, I think maybe they will decide to change it. I don't know. And then if you look at the genetic subtypes, so the genetic subtypes of diffuse large B-cell lymphoma, they take from the Hans classification of lymphoma. So based on the expression of the CD10, BCL2, and BCL6 in the Hans allogram, they define diffuse large B-cell lymphoma based on the expression. So the activated B-cell type, also known as the post-germinal centers, they often have a poor prognosis and they tend to express MUM1, CMYC, and also other markers. And if you look at the nose, is when they do not express things that are within the expected range. So they can be positive for BCL2, CD10, BCL6, and a bit of MUM. And then the germinal center subtypes that are positive for CD10 and then BCL6. So in the genetic subclassification, they look at the genes that are expressed, and they found that in the EZB and S2, ST2 type, they often fit into this, what is known as the previous germinal center subtype. And then the BN2 fits in the NOS classification, and the rest fits into the ABC subtype. However, it's not as straightforward as it looks, because in essence, it looks like this. So it's not a fast and hard rule, because you can have the MCD genetic subtype that belongs to the unclassified, and you can have MYC positive or negative that belongs to the unclassified, and they can also belong to the ABC subtype. So the question is, when do you then do things like MYC and BCL2 and CD10 to find out if ever you have the double hit and the triple hit lymphomas, and why does it matter? Well, the reason why this genetic subclassification was done was that was based on this article by Wright. And what they did is that they've taken biopsy of a lymphoma and they put that into the LymphGen algorithm using molecular studies. And in that, they found this genetic subtypes. And the importance of these genetic subtypes is because you have drug targets against this genetic subtype. So hence now, are we still going to be using the Hans algorithm to classify lymphomas? And unfortunately, in South Africa, and I know here where I'm working in the States, that it's nice to know for academic reasons. However, once the patients are referred to oncology, this becomes obsolete, because patient, if the lymphoma expresses CD20, which all diffuse large lymphoma expresses, except for one, then the patient will be given R-CHOP anyway. However, there are cases where patients receive R-CHOP and then they undergo remission and the resistance to the R-CHOP, and hence where this alternative pathway of drug targets will be very important. And I know in private practice, the oncologists will often request targeted therapy, and they will request pathologists to do molecular studies because of the targeted therapy. And unfortunately, even then, some of these targeted therapies are not approved, or medical aids are not willing to pay for them, and hence patients sometimes they jump through the hoop just to get the approval from the medical aid. And it's often a catch-22 with this molecular studies in lymphomas, because you're damned if you do and you're damned if you don't, because ideally we should be able to do, from the diagnostic point of view, this molecular studies so that the patient could have an alternative treatment. However, once you do that, and the patient cannot afford it, and I don't know, it's like it's a false hope where there is a treatment, but the patient cannot afford the treatment. Unfortunately, in government, we don't have this yet. So plasmablastic lymphoma, it's a lymphoma that is very common in the oral cavity. Actually, if you look at the cases that have been published so far, about 90% are in the oral cavity and the rest are in the GIT. And it's called plasmablastic lymphoma because the cells have a plasmablastic morphology. And unlike all the diffuse large B-cell lymphomas, and especially because it's a variant of a diffuse large B-cell lymphoma, plasmablastic lymphoma does not express CD20 on immunohistochemistry. Therefore, patients will not benefit from rituximab in terms of treatment, but they still get other types of chemotherapy, especially here in government. And what is important is that the cells expresses plasma cell markers, the most common one being MAM1, RF4, and BLIMP1. And the cells in plasmablastic lymphomas, they show a rearrangement in the MYC gene. That's because they have a mutation affecting the JAK-STAT pathway. So this is a case that we've seen here with the patient presenting with a lesion in the palate. So this is the palate, the upper lip, lower lip, and then you have the teeth. So a patient presented with a nodular lesion of the palate. It was red velvety, and the biopsy was done. And this biopsy showed a highly proliferative hematolymphoid tumor. The reason why it has changeable body macrophages is because there's an increase in cell turnover, and that result in cell death and a lot of mitotic activity, and hence the changeable macrophages. And then if you look closely, the cells have a plasmablastic morphology, and the cells are positive for MAM1, negative for CD20, and also positive for EBV. So what is the role of Epstein-Barr virus in plasmablastic lymphomas? In the initial phases, one could not diagnose plasmablastic lymphoma without a positive EBV. So it was frowned upon. So if you have a negative EBV, the one thing that you'll consider is a plasmablastic myeloma. However, there are cases of negative EBV, plasmablastic lymphomas, and one should not shy away from diagnosing plasmablastic lymphoma if the EBV is negative. We had, I think, last year 2 cases where it looked like a plasmablastic lymphomas. However, the EBV came back negative twice, and we had to send it. I think one case, my registrar, Dr. Mavuso, had to take it to vets for confirmation, and it was plasmablastic lymphoma. So it's always, especially in the oral cavity, it's always you doubt yourself if the morphology fits and the EBV is negative, but there are cases of EBV negative plasmablastic lymphomas. So what is current in South Africa? This article was published in 2017, where they looked at the 20-year review of lymphomas, head and neck lymphomas at vets, and they found out of 22,000 cases, 504 were lymphomas. The HIV status was known for a few of those cases. It's only 218 were positive, and 157 EBA positive, And of this, in the head and neck, of the 504 cases, 159 cases were plasmablastic lymphomas. And this was roughly at the peak of the HIV pandemic. And what is happening in the rest of the world, rest of the country? So this was in Cape Town. The study was done in Cape Town. So they looked at Hodgkin lymphomas in HIV positive and HIV negative patients. And they found out of the 303 cases of Hodgkin lymphoma, 77 were HIV positive, and the CD4 count cell at diagnosis was 225, so they're common in the lower end of the CD4 count. However, I've taken this from the same article. If we look at during the almost like maybe the peak or the end peak of the HIV pandemic, and you look at the prevalence of Hodgkin lymphoma in HIV positive patients, you see that actually it's outnumbered by the HIV negative patients. And there was, it goes through phases where you have peaks and then it goes down again. But in terms of comparing the HIV positive and negative, the HIV negative group still present more with Hodgkin lymphoma compared to HIV positive group. And looking at Beckett lymphoma, because Beckett lymphoma in HIV is associated with EBV infection. And in this case, the study was published this year in 2025, and they looked at the pattern of incidence of Beckett lymphoma. And in the study, if you look at the head, neck, and face over the years, because they looked from the 19 to 2021, and if you look in the head and neck, during the peak time of HIV infection around this two, you see that the cases of Beckett lymphomas in the head and neck were still low compared to the population at that time. So out of the 382 in the head and neck, there were only 17 cases. And then if we look at the this phase from 2004 to 2015, you had 157 cases of Beckett lymphomas. And then they started going down. And maybe this could be a reflection of patients being on ARV treatment and also the decline in the HIV pandemic in the country. But in general, if you look at the percentage of head and neck Beckett lymphoma cases, they're still lower than what it's seen in the from nodal disease and also in the general population. Then there was another study, I think also published this year. Oh, I forgot to put in. So they looked at 8,479 cases, and they looked at the cancer registry of the NHLS and the National Cancer Registry to find out the lymphoma, malignancies in HIV positive versus HIV negative adolescent and young adults in South Africa. And out of the 8,479 cases, only 1,853 patients were HIV positive. And the most common lymphomas were Kaposi, Hodgkin and non-Hodgkin lymphomas, including leukemia. But if you look at, interrogate what they've seen, if you look at the HIV positive versus HIV negative, you'll see also that the incidence of, or the prevalence of Hodgkin lymphoma is lower in the HIV positive compared to the HIV negative. And then the non-Hodgkin lymphomas, which are your diffuse large B-cell lymphomas and plasmablastic lymphomas, they actually outweigh the HIV negative. But then also remember there were cases of unknown immune status. So, and I'm going to explain that just now. And then also this article that was published now in 2025, and they I think 2024, and they looked at the HIV's between they looked at the cancer registry and between 2004 and 2014, and looked at what's the most common cancer or neoplasm, and it was non-Hodgkin lymphoma, making about 1,060 cases, which was still lower compared to 15,000 cases. And the EBV related was 288 cases. And the last one, this was published from VETS, and they in 2022. So they looked at 2007 comparing to 27 cases of diffuse large B-cell lymphomas. And at that time, the HIV positive cases, out of the 114 cases, 89 were HIV positive. And then in 2027, they had 221 cases. And then in those cases, 176 were HIV positive. So what does this mean overall? So I said I'll share what we have experienced at the University of Pretoria Oral Maxillofacial Pathology Department. So this is a study that I supervised of Dr. Bunti Kogi, and he is now a registered MaxFac, was graduating last week, Thursday, CMSA. And what we did, we looked at 228 head and neck lymphomas. And of those, 9 were Hodgkin lymphomas and 290 non-Hodgkin lymphomas. And all we had a male sex predominance, and though in those lymphomas there was a from I think 6 months to up to 10 years follow-up on those patients. So we looked at the E/H status, and we also looked at the HIV status of the lymphoma patients. And in those, we had 133 HIV positive patients, and we looked at the lymphomas and their EBV status. And you see Beckett lymphoma, we only had 1 case of Beckett lymphoma in those HIV positive patients. And the majority of the lymphomas were diffuse large B-cell lymphomas and plasmablastic lymphomas. However, EBV positivity was more common in plasmablastic lymphomas than was for Beckett lymphoma. And then also we only had 4 cases of Hodgkin lymphoma in that 10-year period. So we looked at the lymphomas in a 10-year period. And also what's interesting is that patients with HIV also presented with myelomas, and these were patients that were younger, and some of the myeloma patients had EBV positivity, which I will discuss just now. And in this study, we looked at the CD4 count at diagnosis. Now, there are different issues in South Africa when collecting data, is that patients only have their HIV status checked after a diagnosis. So hence, if you look at the studies that were previously published, I think it's not a true reflection of the HIV pandemic, because 99% of the time, you do not have, especially when you go back on records, you don't have the patient's HIV status at the time of lymphoma diagnosis. So you have to search on the system. And the problem with the lymphomas is that some patients would die before they get into the system, they get to oncology, and hence it's difficult to find the HIV and the CD4 count. However, if you look at the CD4 cell count, majority were below 500,000 CD4 cell count at the 500 at the diagnosis. And if you look closely, patients with plasmablastic lymphomas, they have the lowest CD4 cell count at diagnosis. And then we also did a follow-up and looked at the overall survival based on the EBV status. And you'll see that there was no significant difference between the overall survival of the EBV positive versus the EBV negative lymphomas. Also, when we looked at the HIV status of the patients, the negative group tend to progress slower, and then the HIV positive group mostly died following diagnosis. However, the data is skewed because we had a lot of patients that are HIV positive versus the one that were HIV negative. So based on the study, we found that plasmablastic lymphoma and diffuse large B-cell lymphomas were the most common head and neck lymphomas in HIV positive patients. And these patients were with lymphomas had the lowest mean CD4 count of less than 500 at diagnosis. And plasmablastic lymphoma patient had a median cell count of 147 with advanced clinical stage. And EBV co-infection was detected at 84% of HIV lymphoma patients. And the overall survival of patients with plasmablastic lymphomas was 45 months. So I would like to share, after this presentation, I'd like to share like now cases that we've seen in our institution. So this was, if I could remember, it was a 35-year-old female patient who presented with an ulcer in the floor of the mouth. And she complained of difficulty in swallowing and moving the tongue. So the tongue is elevated in the top. So this is the floor of the mouth and these are the lower teeth. So I would like to stop sharing because I want to share the slides. So we received an incision biopsy from the floor of the mouth, and this, just to confirm, you have the overlying mucosa. So this is the overlying surface mucosa, and then this is the duct of the minor salivary gland going on top, and then you have adipose tissue. And if one look very carefully, you have a polymorphous infiltrate of cells. So you have eosinophils in the background, you have plasma cells, you have lymphocytes, and then you have this larger cells that can be seen, the Rustenburg-like cells. You can see that's another one there and another one there. And then also you have some immunoblastic cells. So just to make it interactive, I just want to know if anybody has thought of a diagnosis immediately. I can't see the chat, so I will rely on the on Lunka to the chair to share what's in the chat.
There's no dates at the moment.
Unless if they want to look more. And I just want to highlight things
We've
like
got
this.
somebody, Batsi Batovejan is saying EBV associated mucocutaneous ulcer.
Yes, so that is correct. This is an EBV mucocutaneous ulcer. And if you're used to looking at Hodgkin lymphoma, once you start seeing eosinophils, and I think it's a bad thing that we train students that once you see eosinophils, you should think Hodgkin lymphoma. And here you see a lot of eosinophils, and then you see these cells. However, I just want to highlight also this cell here. If one can see, there's a larger cell here. I think there was another one here. There's a beautiful one here. So I don't know if anybody has any additions to add to this.
There's a suggestion of CMV.
That's a great suggestion. So this is a case of a patient with of mucocutaneous ulcer with co-infection with cytomegalovirus. And the lesson here, especially for registrars in the chart and also for pathologists, is that in HIV, there's always dual pathology, and one needs to be careful of looking for one pathology and not seeing the other type of pathology. So this is one case that was nice of EBV mucocutaneous ulcer and EBV infection. So you can see those larger cells with the all-I nuclear and intranuclear inclusion. And they tend to mimic Hodgkin cells, and one can actually dismiss them if you look at this, you can think it's a mummified Hodgkin cell and dismiss it as such. So this was a case with the dual pathology. Unfortunately, I didn't scan the CMV and the EBV, but I hope you can take my word for it. So it's a nice, interesting case. I'm going to share another case, and just to highlight the importance of clinical management of patients as well. So this gentleman was a 31, 32 age group male patient who went to a dentist complaining of loose tooth. And what the dentist did is that even with this beautiful dentition, the dentist didn't think that there could be something sinister going on. So what the doctor did was just to extract the loose tooth. And following the extraction, patient went back to the same dentist and said, I've taken out this tooth, but now this thing has grown out. And it was this massive lesion involving the palate. It was perforating the cortical bone and extruding into the buccal space. So this patient then was treated for what is known as post-extraction granulation tissue. However, it didn't heal. And then patient doubled in size and then came for a biopsy. And so I just need to share. So patient came in, had a biopsy taken. So the biopsy, just to show you, this is mucosa on the surface because it was taken from the oral cavity. So you can see there is a diffuse proliferation of hematolymphoid cells. If you go back in areas like this, you will see that the cells have eccentric nuclei with prominent nucleoli and here. And in addition, some of them have an immunoblastic morphology, but these were large cells. And from my pathology training, this what I was taught, that if you want to determine the size of a lymphoma cell, you must compare it to endothelial cells. So a large cell lymphoma, the size of the cells will be larger than an endothelial cell. So we can safely say the cells are larger. So I don't know if there is any stain that anybody wants to order for this case. Any takers on stains?
There's a CD20 request.
CD20.
Mom 1.
Wait, I'm still on CD20. So this is 20. Just to confirm, it's the same tissue, and you have reactive B lymphocytes, but basically the whole tumor is negative.
Mom 1.
This is mom one, sorry. Okay, another thing.
Iba-ish.
Just to confirm the control is positive. So we have positive Iba-ish staining. And just for fun, I think I did another stain. Oh, I didn't show it here. So
There's
the
also a
also
request for 138 and a CD30.
oh no, not done. I once I have one marker for plasmacytic differentiation, I don't do more.
Okay, then the CD30.
Wasn't done.
Okay.
And then that's another stain. Sorry. So we did a CIMIC. So it's a mixed stain. Okay. Any takers for diagnosis? Sorry, I can't see the chat. So if there are
I'm
any
waiting for the takers.
excuse me?
Plasmablastic lymphoma.
Yes, so this was a plasmablastic lymphoma. Let me stop sharing this one. Okay, so in retrospect, this patient had more than a plasmablastic lymphoma. So there's a history of lymphadenopathy, cervical lymphadenopathy, which was massive. And the patient turned out to be HIV positive, but post-lymphoma diagnosis. So this patient was diagnosed with HIV plasmablastic lymphoma and received chemotherapy. And I think he was one of the few that got radiation. The last follow-up, because based on the study, the last follow-up was 22 June 2023. He was one of the slow progressors because after he's been on ARV treatment, there was actually a longer disease progression. So he was still alive, I think, 3 years post plasmablastic lymphoma diagnosis. And the thing about plasmablastic lymphomas, I don't know if because they don't express CD20 and hence there's few treatment options, but they tend to not do well with the standard chemotherapy regimens. However, if they go on ARVs alone, it shows a significant improvement in the disease. And it's something that one needs to look out for. And having just said that, thank you very much for your attention. And I'd just like to thank the South African Medical Research Council grant because the part of the study, which I'm doing for my PhD, some of the results that were presented here, especially the EBV staining, were paid for by the money that I received from the South African Medical Research Grant. I also like to thank the Haematology Deep Dive for the invite. Thank you very much. And these are my references. And then I'll take questions.
Thank you so much, Prof. Tulufelo, for such a detailed presentation with a lot of take-home messages. The floor now is open for questions. And maybe whilst people are still thinking, I just want to ask from my side, for CIMIC or MIC positivity on immuno, I know the case that you presented, it was a diffuse positivity, but do you have a cutoff what you regard as positive?
Based on the algorithm, the simic positivity, one still needs to confirm it with molecular studies. Even though they mentioned that because the current immunohistochemistry is compatible with the staining. And from personal experience, I found that it's all or nothing. You either get more than 80% simic staining or you have zero staining. So we do have cases where the simic is completely negative. But it's like EBA in this plasmablastic lymphomas. It's always all or nothing. You either get complete negativity or diffuse positivity.
Okay, then just a last one from my side. Interleukin 2, do you have it as a routine?
No, we
routine test?
don't. No, we don't. We don't even use that in government. The reason I put that in is because that's what's currently being used out there, but we don't have it.
Okay, thank you. Thanks, Piwa. Dr. Balo, you've got your hand. You can unmute and ask your question.
Thank you so much for a very lovely presentation. I think you've really highlighted a few, quite a lot of key points here. I may have missed it, but you had said you were going to touch on EBV infection with in cells which are with plasmacytoid differentiation. Maybe just to reiterate that. And then the other question I wanted to find out if in your practice you're seeing patients with other immunodeficiencies coming through, not just HIV, maybe someone with primary immunodeficiencies.
I only presented the studies, the results of HIV because of the talk. However, two of the patients had plasmablastic lymphoma, one from immune suppression for autoimmune disease, and the second one was a patient who had a heart transplant who presented with a plasmablastic lymphoma. So yes, we do see other immune suppression outside HIV infection. And in terms of your first question on EBV, I did touch on it, that with plasmablastic lymphomas, what we see here is that it's difficult to diagnose plasmablastic lymphomas without EBV, but there are cases of EBV negative plasmablastic lymphomas. But in the oral cavity, like I only seen 2 cases where I actually had to send it for consult because I doubted myself, even though the morphology was plasmablastic morphology, the CD20 was negative. However, and the Ki-67 was higher, so it can't be a plasmablastic myeloma. But the EBV was negative, so you do get cases that are EBV negative for plasmablastic lymphomas. I'm not sure if I've answered your question.
No, thank you very much. Actually, now as you started speaking, I realized that you did answer that question a bit earlier, so I appreciate it. And I just wanted to find out in terms of collaboration and how are you sort of collecting the data, and is there any way we can help and work together with you?
Oh, there's always room for collaboration. I can put my email on the chat box for anybody that's interested in collaboration. I'm based in oral and maxillofacial pathology at the University of Pretoria. But I mean, there's always collaboration. I'm interested in interdepartmental collaboration and also like institutional collaboration. So I'll put my emails on.
Any other questions? We're getting a lot of people saying thank you for the excellent presentation. Tulufolo has posted her email address on the chat box. More people saying the presentation was enlightening. Yes, Nicole.
I see Prof. Adam Bag is in the audience from University of Pennsylvania, Hempath. I don't know if he has any comments or questions to join in.
Hi, hello. Thank you for spotting me. I sometimes like to travel incognito and alter my name, but Zoom wouldn't let me do that. No, a great presentation, and obviously enlightening to hear about the different distribution of HIV-associated lymphomas in South Africa. So it's been very educational for me. Thank you.
Any other questions? People can just mute and proceed.
Sure. I think we, as in hematology, don't see nearly as many of these patients. And I think at our center, Zainab is the one who primarily looks at some of these. I don't know if Zainab wants to chime in with any of your experience or any observations that you've made on your side.
Hi. I just wanted to say we see plasmablastic lymphoma in multiple sites, multiple extranodal sites, mostly in the neck area, but our commonest head and neck lymphomas are diffuse large B-cell lymphomas. And for our plasmablastic patients with localized disease, we actually do add radiotherapy onto their chemotherapy. And some of them don't do too badly. And what you were saying about patients' immune response to the ARVs, that really does make a difference. We have had a few HIV negative patients that we struggled with. Yeah. But thanks for a really good presentation. Thanks, it's really interesting. And that you've amassed so many head and neck lymphomas. I think our head and neck team might be interested to know about this. Thank you.
Actually, I do have one question, if I may ask. It's my understanding that with the introduction of antiretroviral therapy and improvement of the immune system of individuals with HIV, the frequency of lymphoma decreases as one might anticipate. However, there are publications from quite some time ago that I'm sure you're familiar with, reporting that the frequency of Hodgkin lymphomas actually tended to increase with the use of antiretroviral therapy because, or assumed to be because, the immune system, the microenvironment is so important in the biology of Hodgkin lymphoma. And so my question is, has that been the experience in South Africa as well, or has it been something different?
Thank you for the question. The reason I put this study on is because in South Africa, it's a different experience, because if you look at the Hodgkin lymphoma on the study, the top, even though Hodgkin lymphoma is 1, 2, 3, 4, 5, it's top 5 in HIV. But if you look at how many cases, the frequency is still lower than what will be expected. And also, if you look at this other study of between Hodgkin lymphoma in HIV positive and negative, the cases are still lower compared to what it's been written out there. And I know in some articles they talk about yes, the role of ARV in basically changing the balance of the immune system, and that's the reason why there's an increase. But we don't see it, and maybe because our tumors are mostly because of viral oncogenesis. Maybe I'm just assuming that, because if you look at in other countries, Hodgkin lymphomas and most of them, they do not express EBV, and with ours they tend to express EBV, and maybe the ARV, because of suppression of the EBV, maybe that's the reason why we see less cases, because this is our study, this is what we've seen in our institution. over a period of 10 years from 2011 to 2021, we only saw 4 cases of Hodgkin lymphoma in the institution. And these were all EBV positive. None of them were negative. So maybe EBV plays a role in our setting, and hence we don't see a rise in EBV in patients with who are on ARV. But then we still have the lowest antiretroviral coverage. So maybe things will change.
Thanks very much.
Yeah, just to add on to that, in Cape Town, I must say I don't have the data off the top of my hand, but that's also been our experience. As I felt that we've seen more Hodgkin's patients with HIV, but because of the ART coverage and maybe various other factors, we sort of get quite a heterogeneous mix. And so the patients with advanced stage HIV who end up with Hodgkin's lymphoma often present with primarily, I won't say isolated, but predominantly bone marrow Hodgkin's, with very minimal in terms of the other nodal sites, but universally, they seem to all do quite poorly in terms compared to the HIV negative counterparts. And what we've also struggled is we've really struggled to get any of our HIV positive Hodgkin's to try and salvage them if they relapse. That's been quite a nightmare as well.
There's a question from Dr. Govenders asking, do you place any value on EBV and CMV serology, or is the morphology and immunostains sufficient to build diagnosis?
Because of the way I train, because we are in pathology, so our diagnoses are based on what we see on morphology and also what we see on immunohistochemical stain, which is a confirmatory stain. But we don't do bloods to confirm EBV, or we don't do bloods for CMV. It's based on what you see in morphology, then you order the stains, and then you make a diagnosis.
Thank you. Any other questions?
Hi, sorry, it's Zainab on my phone. I couldn't put my hand up. I just wanted to just sort of reiterate what CPW said about the Hodgkin's lymphoma. The HIV positive patients with Hodgkin's lymphoma mostly present with advanced disease. So they get biopsied from other sites other than the head and neck area. We very rarely, and even with our HIV negatives, we very rarely see early stage Hodgkin's lymphoma or your typical Hodgkin's lymphoma. We would, yeah. We often see atypical sites, and particularly in the HIV positive patients. Thanks.
Thank you for that comment. I think in the absence, is there a question? Yes, in the absence of any further questions or comments, it is for me to again thank Prof. Tsulufelo Kungwane for this wonderful presentation, and thanks for the audience for being interactive and for the questions and comments. And we can bring our session to an end, and wishing you all a good evening.
Thank you to the audience, and thank you, Chair, to you. Thank you, Nicole. Thank you for the invite.
Thanks, Limpa. Thanks, Prof. It was great to have you here.
Thank you. Bye. Enjoy the evening.
You too. Bye.
Bye.
I mean, wait, the 31.